Jeffrey Kahn. I'm the director of the Berman Institute of Bioethics, and it's my pleasure to welcome you all to the Roberth H. Levi Leadership Symposium. I get the honor of telling you about Roberth Levi and his wife, Rita, after whom the symposium is named and why we're here. And then I'll turn it over to my colleagues to talk about today's event. The Roberth H. Levi Leadership Program in Bioethics and Health Policy was established by a gift from the Levi family in 1997 in honor of the late Roberth H. Levi, who as an alumnus and trustee of both Johns Hopkins University and Johns Hopkins Hospital, played a major role at Hopkins for more than 3 decades prior to his death in 1995. He was president of the Hecht Company department stores, for those of you who remember that institution here in Baltimore and Washington, and a civic leader and really generous philanthropist. In addition to being instrumental in the revitalization of downtown Baltimore and serving on the boards of many Baltimore institutions, Mr. Levi was a patron of the arts and gave generously to the Baltimore Symphony Orchestra and to the Baltimore Museum of Art. You may know that the sculpture garden at the BMA is named the Levi Sculpture Garden. Baltimore and Hopkins benefited greatly from his extraordinary work and his deep personal commitment. In the obituary that ran for Roberth Levi on February 21st of 1995, the Baltimore Sun observed that, here's the quote, his adult years were one long crusade of giving back, and that he made sure his donations were put to good use. That's my addition. In short, he cared deeply about making a difference to the community in which he lived and to Hopkins. As did his wife, Rita, who was at the forefront of both resisting and then working to change the social norms of the 1950s here in Baltimore that included barriers of race, religion, and social class. And she left a truly lasting impact on this community as a result. The goal of the Roberth H. Levi Leadership Program is to raise the level of ethical discourse about critical issues in medicine and social policy, both in the community and among those who have the practical responsibility for addressing them, through a public event on a current topic of importance to the nation. That's why we're here today. And so we are honored to have the Levi name associated with these symposia, and while members of the Levi family are not able to attend today, they ask that I send their warmest wishes. So it's now my pleasure to introduce my colleagues, Renee Voss and Becky Seltzer, who are co-chairing today's symposium. I will introduce them, and then Becky will come up and introduce the symposium. Dr. Renee Voss is an associate professor of neonatology and palliative care at Johns Hopkins University School of Medicine and is a core faculty in the Berman Institute of Bioethics. Her research focuses at the intersection of palliative care, bioethics, and neonatology, and targets parent-clinician communication and decision-making for the sickest infants and children in the intensive care unit. Her recent work is centered on children with chronic critical illness, particularly those with repeated and prolonged hospitalizations and dependence on medical technology. This work explores the experiences of clinicians, families, and health systems in caring for these children. Dr. Rebecca Seltzer is an assistant professor of pediatrics in the Division of General Pediatrics and Adolescent Medicine at the Johns Hopkins School of Medicine and faculty in the Berman Institute. She's an attending physician at the Harriet Lane Primary Care Clinic, and her clinical and research interests focus on improving care for children with medical complexity, children in foster care, and the intersection of these two populations. She's exploring the ethical and policy challenges that arise when caring for these populations, including challenges related to medical decision-making, conducting research with the vulnerable population, and gaps in community supports and placement options for children with medical complexity. So you see why these two are chairing today's event. And so it's my great pleasure to ask Becky to please come to the podium and introduce today's program. Thank you all for being here.
Thank you all for being here. This is really exciting. It's been about a year now we found out about starting to plan this, and it's just been wonderful working with all the people that have been involved, and really excited to have an interesting and exciting discussion today. So today's panel is the first event in a larger 2-day symposium focused on exploring the ethical challenges to gaps in placement options, community supports, and services for children with medical complexity. Dr. Boss and I became interested in this topic through our clinical and research work, as Jeff mentioned, related to this population of children. Before convening an interdisciplinary working group tomorrow, where we're hoping to think through what policies and programs we should be promoting to address the needs of this population of children within Maryland, we wanted to first step back and think about how to define a, quote, good outcome in this context in order to know what we should be working towards. Through commentary from our panelists and subsequent discussion with all of you, we hope to hear varying perspectives of what defines a good outcome for children, families, and systems of care in the context of pediatric complexity. I will provide some brief introduction to this topic, and then we'll introduce our panelists and invite them to come up. But first, I want to take a moment to thank the Levi family for making this symposium possible, and Jeff for that nice introduction. I also want to thank Dr. Joan Kaufman and Paul Brolsky from the Kennedy Krieger Institute, who've been really instrumental in helping us plan these events, and Jessica Reisenen, Suzanne Knisner, who I mispronounced her name, and Jamie Smith for their logistical and technical support, and none of us would be here today if it wasn't for them, and you've probably gotten a lot of emails from them, so thank you. While there is no universal definition for children with medical complexity, or CMC, one commonly used definitional framework by Cohen et al. Defines CMC based on 4 domains. These children have substantial service needs, at least one chronic condition that is severe and or associated with medical fragility, functional limitations which are often severe and may require dependence on medical equipment or technology, such as feeding tubes or ventilators, and high healthcare utilization, often with recurrent hospitalizations and involvement from multiple medical subspecialists. Here is an example of a child with medical complexity to provide some context for discussion. This is Gabby. She is a 3-year-old girl with chronic lung disease, cerebral palsy, intellectual disability, and seizure disorder. She has a tracheostomy and ventilator to breathe, and a feeding tube for all of her nutrition. She has been hospitalized 5 times in the last year and follows outpatient with a primary care doctor and 8 different subspecialists, in addition to physical, occupational, and speech therapy. And we'll come back to Gabby's case shortly. So just some background numbers. The population of CMC, like Gabby, is growing, in part due to advances in neonatal and critical care medicine, technology, and nutrition. Children with once fatal conditions such as extreme prematurity or complex congenital anomalies are surviving, but are requiring intensive daily care needs. As there is no single definition for CMC, published prevalence rates vary, but tend to be reported around 0.5% to 3% of children in the U.S. And while this is a small population of children, they are expensive, accounting for 1/3 of pediatric healthcare costs and just over 50% of inpatient healthcare costs. According to the Children's Hospital Association, children with medical complexity represent only 6% of all children enrolled in Medicaid, but they account for over 40% of all Medicaid spending on children. And there are also significant financial burdens on families, with the majority reporting financial difficulties and or a family member having to quit work to care for their child. Children with medical complexity are at high risk of adverse medical, developmental, psychosocial, and family outcomes. These children and their families face many challenges. Medical challenges associated with the intense daily care needs or the child's medical fragility, challenges with access to health care, including inadequate insurance coverage, or having to travel sometimes 2 to 3 hours just to get to a needed subspecialist. Psychosocial challenges such as isolation from family and friends during recurrent hospitalizations, caregiver burnout.
Move the mic to your face.
The mic closer? Can you hear me in the back? Okay, better? I've never been told I don't talk loud enough, so just let me know. Psychosocial challenges such as isolation from family and friends during recurrent hospitalizations, like I mentioned, caregiver burnout, stress, anxiety, less time they're able to spend with their healthy children, financial challenges, and significant time and effort spent coordinating care. This is an example of a care map, which is a visual representation that families can create to show the various systems, services, supports, and individuals involved in caring for the child. I don't intend for you to be able to read every single one of these bubbles, but rather to look at how difficult it would be to coordinate care and communicate amongst these different entities. For some parents, these challenges are overwhelming, or they have additional social or personal health challenges of their own that prevent them from being able to care for the child in their home. For children who cannot be cared for at home by their biological families, what are their options? Placement with a specially trained medical foster care family, placement in a congregate care setting, such as a group home or a long-term care facility, or if no placement can be found, some of these children remain in the acute care hospital while awaiting a placement, or we have to think about placement options out of state. So now back to Gabby. She was recently hospitalized for a respiratory infection and has been in the hospital for the last 2 weeks. She's now stable for discharge home, but the medical team has brought up some concerns that they think mom is really struggling to take care of her at home. Mom has 2 other young small children and has no other family supports. On review of Gabby's chart, she's missed multiple medical visits over the last several months, and there's been concern that she hasn't been gaining adequate weight. So the team's now trying to figure out what is in Gabby's best interest as we think about discharge planning for this child. In order to guide this planning and decision-making, we must first consider what are the outcomes we are hoping to achieve. For example, if we prioritize Gabby remaining in a home setting with her family, then we need to consider what additional services and supports could better support her mom in caring for her. If we prioritize compliance with all medical plans and follow-up visits, then we must consider what other placement options exist if mom cannot meet these standards with available resources. As mentioned previously, children with medical complexity and their families may receive services and support from a wide network, including primary care and specialty medical providers within the healthcare system, community and state-based services such as early intervention, social services, and home health services, school-based services, financial support such as insurance and child care subsidies, and many others. And within such a complex care network, these separate systems, services, and individuals may have their own priorities of what outcomes matter, which may or may not align with one another. Therefore, coming to consensus on what defines good for an individual child may be up for debate. As we think about defining a good outcome in the context of pediatric medical complexity, it may depend on what perspective you are considering. The child, the families, the healthcare system, social services, Medicaid, others. And with that in mind, I will introduce our panelists and invite them to share their thoughts on today's topic. After their comments, Dr. Box will come up to facilitate the discussion. Please save your questions and comments until after all the speakers have finished, and we hope to have a great discussion with all of you and hear what your perspectives are on this topic. So with that, if I can ask our panelists to come up and I'll introduce you. So, first here we have Marisa Berry. She's been the primary caregiver for her daughter Alexandra since 1999 and the mother to 2 other children, Nicholas and Daniel. She is an advocate for other parents and caregivers of medically complex children, and she's the administrative assistant in the Office of Howard County Pediatrics. Next, we have Dr. Margaret Moon, who's the Chief Medical Officer of the Johns Hopkins Children's Center. She is an associate professor of pediatrics in the Johns Hopkins School of Medicine, core faculty in the Berman Institute of Bioethics, and the Freeman Family Scholar in Clinical Ethics. Dr. Moon sees patients in the Johns Hopkins Harriet Lane Acute Care Clinic, and she teaches clinical ethics and medical legal issues to medical students and residents at Hopkins. Rebecca Jones-Gaston is the Executive Director of the Social Services Administration within the Maryland Department of Human Services. She provides strategic vision and guidance for transforming Maryland's social service system. She has worked in the field of human services and child welfare for more than 20 years as a social worker, advocate, therapist, consultant, and administrator. She has extensive experience in community engagement, parent partners, mental health, and achieving permanency for children in care. Debbie Marini is the Director of Placement and Permanency at the Social Services Administration. Prior to this position, she was Director of a treatment foster care program. She has over 20 years of experience working in the field of child welfare, primarily treatment foster care, adoption, and community-based services. And Dr. Chris Feutner is a pediatrician, clinical investigator, and ethicist at the Children's Hospital of Philadelphia and the University of Pennsylvania, who focuses on improving the lives of children with complex chronic conditions and their families. Over the years, he has conducted a wide variety of research projects and been involved in developing clinical programs while also taking care of complex pediatric patients, including providing palliative care as well as providing clinical ethics consultations. Thank you all for being here today on this panel. Particularly thank you to Rebecca Gaston and Debbie Marini, who stepped in last minute when two people who you may have seen were the names that were going to be on the panel had some last minute emergencies. So thank you all for being here. And I'm going to let Lisa come up to start.
Just leave those up. This is a large group. I'm not going to pretend that I'm used to doing this. Okay, take care of my kids, take care of some other patients and their parents, but this is outside my realm, so bear with me. This is Alexandra. She's going to be 20 in April, which is unbelievable to me. I tell her all the time that I'm too young to have a 20-year-old, obviously. We've been raising her since she was 6 months old. She was born at University of Maryland. She spent 4 months there. She spent 2 months at Mount Washington Pediatric Hospital. And then she came home, she was born in April, she came home in October. So we've been taking care of her since then, with the help of nursing care, obviously. She has 2 younger brothers, as was said. They are 15 and 11. They are becoming more adept at communicating with her and helping her. Interestingly, the 11-year-old has learned how to suction her. And he does quite a good job at it, honestly. I don't leave her with him, no worries. He is not medically responsible for her, but if I'm home, he wanted to learn, so I taught. She has an intense interest in Food Network and all things culinary. She does not eat by mouth. She is G-tube fed and always has been, but loves food. She also has developed a strong interest in dance and music. She's got a long list of music on her iPad. She plays it at school. She was playing it today because we didn't have a nurse, so my husband had to stay home with her while I went to work. And she was entertaining him all day with her playlist. She is currently going through the career assessment phase of her life. She is still in school at our local public high school. She's never gone to Cedar Lane, which is a Howard County school for kids with disabilities. She is in our mainstream school, always has been. So she is what they call a super senior, which when she told me, I said, well, clearly you're super. I already knew that. She said, no, that's the name of a second-year senior. Okay, understood. I don't think that our school system had encountered someone like Alexandra before. She is medically fragile and very disabled, however, intelligent. Not like Mensa intelligent, but she is on grade level. She is going to graduate with a diploma, and so it's been interesting, I think, for them and for us. She repeated the 4th grade after she had her spinal rods put in, and that resulted in some infection. So she repeated 4th grade. She's repeating 12th grade now, as I said, because she had some more classes to complete. She may be there one more year to do some principles of business class. Yeah, who knows? Looking past high school is terrifying. I went to one seminar called What to Do When the Bus Stops Coming. I have no idea. I still don't have any idea. But we are soldiering on because that's what we have to do. Although I did learn, after I wrote this, I thought we don't actually have to. I have heard of other parents making the decision not to take their child home from the NICU, which is what I learned when she was in the NICU. That was never an option for us. Her list of equipment and supplies is staggering. Makes me wish for an addition on my home to keep it all in, so that sometimes I could be in a room and not be staring at her equipment and supplies in baskets and everywhere. She has a trach, a ventilator, a VP shunt, a G-tube, a feeding pump, Foley catheter, spinal rods, a power wheelchair, an adult stroller, a tumble form chair, a bath chair, 2 suction machines, a cough assist, a nebulizer, oxygen tanks, a concentrator, a Hoyer lift, a pulse oximeter, supplies on her door and in her closet, a hall closet, and a basement closet full of supplies. She has a wheelchair accessible van. She has ramps to get in and out of families' homes and other non-accessible places. If you're in our home, you're never far away from her goods. They're everywhere, either hidden or otherwise. She's cared for by pulmonary, neurosurgery, ENT, orthopedic surgery, urology, nephrology, ophthalmology, her dentist, her OT, her PT, her speech therapist, her rehab specialist, and her primary care doctor, and I'm pretty sure I left out a couple people. We've met a lot of people here. We've met a lot of nurses in the PICU. Over the years, she's been there, probably for her first 10 years, she was there for at least a week with pneumonia, even though she's not, her disease is not in her lungs. She's spina bifida, forgot to say that, with Arnold-Chiari malformation. So her brainstem was damaged and affected her breathing. So her lungs themselves are not primarily affected, but she does get sick easily. So she sees a lot of people. She also has nurses who go to school with her. She cannot go without one, and that is solely for her respiratory needs. She needs somebody there who can keep her airway clean so that she can breathe. And without a nurse like today, she can't go to school. She uses assistive technology, which I don't have a picture of here. The one that we currently have is an accent. It uses eye gaze and a switch for her to speak. It is very slow. She used to have a Toby. She has the accent, similar to what Stephen Hawking used, similar to what O.J. Briggins uses for the Ravens. But that is not to say in any way, shape, or form that she is not vocal. When it is 8 o'clock on any given day, she can make very, very loud noises to make sure that you come immediately to her room to turn her music on and put her headphones on. She doesn't care about her breakfast of Jevity. She just wants her music. We've been, like I said, to the PICU many times. The latest one was 2 years ago for 3 weeks. That was her most significant pneumonia. That's when we went home with the cough assist, which I assured everyone we did not need because I had enough equipment in my house and I had no more need for anything else. But we were told we weren't going home without one, so I quickly said, sign me up and deliver to my house, let's go. And she uses it frequently, and it's a pretty awesome machine, actually. When she was younger and was visiting every year, it felt a little bit like Norm on Cheers. Everyone would say, hey, Alexandra, hi, everybody. It was comforting and saddening at the same time. But trips outside of coming to the NICU have made her happy and joyful. She's been to Dancing with the Stars at the Lyric. She's been to the New York City Wine and Food Festival, of course. She has met other Food Network celebrities at Barnes & Noble and Williams-Sonoma. She has been to Florida to see the Wiggles when she was in 6th grade. That was quite a trip. Taking her supplies and equipment somewhere is difficult at best. She usually requires her entire van to go somewhere just for her. And then the other 3 people have to go in another car because we cannot fit everything in one vehicle. So those are the things that make her happy, and that leads me to what is a good outcome. And since she was in the NICU, it has always been her happiness. My brother asked me when he went to visit her, what are you going to do? And I said, I just want her to be happy. So that is one of my goals. I know that for the medical community, the goal for her would be medical stability. And she is pretty stable. We use PharmaQuip for her supplies and equipment. They have deemed her stable enough where they only have to come out and do a check on her ventilator, and that's it, which is great. She was recently asked the question by her theater teacher, an English teacher, would you change your astrological sign if you could? And she said, and I asked her to quote it again for me. She said, where did I put it? A person can't change her stars because that's how God made us. And I was impressed, and he put a gold sticker on her shirt, which is how I knew something had happened. She earned something, and that was it. I have other outcomes we can discuss during the question and answer session, but I'm glad to be here. I'm glad to talk about these kids. They need everyone's help. They need a lot of assistance. So I'm glad to talk about it with you. Thanks.
Thanks. It is always so amazing and humbling to hear the stories of the parents who care for the kids that we pay so much attention to. You know, we think we're important. We think what happens in the hospital is like a big deal. And then I hear about every day. Every day is such a big deal, and we are so much a small part of it, but it's an honor. It's really an honor to participate in the care of these kids. So I'm Maggie Moon. I'm the Chief Medical Officer of the Children's Center. I was a resident here, a trained medical student here. I've been around here for a long time, and I'm so thankful, actually, to Dr. Seltzer and Boss to really think about the care of these kids in a much more comprehensive way. Because ever since forever, the care of children with complex medical illnesses has both inspired and bedeviled the Children's Center, right? It's what we do. But it's always felt, it always has felt, it always feels like we could be doing this better. We could be doing this more comprehensively. We could be doing this in more innovative and thoughtful and creative ways. And I'm really happy to see the work that Becky and Renee are doing, because they are the kind of people who can make a difference and can take us to the next level. So let me talk for a minute about the commitment of the Children's Center. So, you know, that Johns Hopkins Children's Center has always been a place where kids come to get the care that they need. And we have a tremendous commitment for optimal patient and family-centered care for all the children that need us, right? So in our community, in the state of Maryland, in the world. That's what we're here for. That's what we intend to be. That's what we intend to do really well. In addition to providing the care of these children, we really are focused on the innovation and the research and the education that will make the world a better place for all children going forward. That's what it is to be here, and we hold that commitment very true to our hearts. Children with complex medical illnesses are increasingly even more and more part of the care that we're providing. Hopkins is sort of turning into, as I think about it, a very large ICU, because so many of the kids that we care for have technology, aren't just sort of easy to care for, a little bit of asthma, maybe a little bit of a sore throat infection, bladder infection, whatever, in and out. So many of the kids that we care for in the Children's Center now have very complex medical illnesses. We even have another population of kids that we call chronically critically ill. These are even more than just complex medical illnesses, kids who have been in the ICUs for months and months and months at a time. So really our patient population is really forcing us to think harder about new ways to provide this care. About a year and a half ago, we had a retreat on innovation. The question of the retreat, this was a bunch of faculty members and some family members, some parents, different kinds of providers from the Children's Center, but also from our colleagues from Mount Washington, from Kennedy Krieger. And the question was, what does Hopkins have to do? What does Hopkins Pediatrics have to do to move pediatrics to the future, to really be the future of pediatrics? It was a fascinating conversation. Everything was on the table. But at the end of the day, what everybody agreed on is that one of our areas of primary focus had to be the care of children with complex medical illnesses, because we understood that we were not meeting our goals to provide sort of the optimal sort of care that's necessary. We really were talking about, it's so awful for somebody to have to bring a child in a van with all their equipment into Baltimore City, into the hospital for a 15-minute follow-up. How could that possibly be a thing? Right? So we talked a lot about telemedicine. Is there something we can do? Can we help these children not have to come into the hospital? What is it that we're missing? What is it that we need to do more of? So it really was a very interesting focus. It was fascinating to me that providers from all different arenas all said the same thing. It's about these kids with complex medical illnesses. What can we do? So I'm saying this because I want you to understand that our commitment is very powerful. Now I want to switch for a minute and talk about where that commitment, what happens to that commitment on a day-to-day basis. So as Chief Medical Officer, I get to start every day with this fascinating phone call. I talk to, at 9 o'clock in the morning, every morning, talk to 25 different people who are bringing reports from their parts of the Children's Center or from our colleagues at Kennedy Krieger or Mount Washington, Peds at Home, all around the people who are working together to care for kids. And we start out by saying, where do we stand today? Who needs us today? Who has to come into the Children's Center today? And how can we get everybody in? So we talk about kids who are coming into the OR. Do they need a PICU bed? How are we going to get them a PICU bed? We talked about kids from the emergency department who may have been transferred in from another hospital or may have shown up with their parents. Do they need to come in? Are there going to be beds? We talk about kids coming from our own clinics. We talk about, I'm looking at my list, we talk about from the floors, getting kids home. What is it going to take us to get the kids home who need to go home? The reason we have this conversation is that meeting our own commitment to providing all the care that we need to provide for all the children who need us, to meet that commitment means movement. It means that kids have to move through the Children's Center. And that's where sometimes this frustration of the care for kids with complex illnesses comes in. When a kid gets stuck in the Children's Center because there's no safe place to discharge them to, I want you to feel the frustration and the anxiety that starts to create, because our commitment is about movement. We want to provide care for everybody that needs our care. But that means that people have to come in and they have to go out. And every once in a while, we have this experience where a child with complex medical illness gets stuck in the Children's Center because there's no safe discharge plan. Either because the systems haven't aligned and nobody's taking responsibility for this kid, because the family's home is not a safe place and we can't create a structure around it. A zillion different reasons, and I'm sure we'll talk about more of them today, and I hope we can talk about a lot of them tomorrow. But what that does to the Children's Center is it limits our ability to meet our commitment to all of our patients. We want to care for every patient who needs us as long as that patient needs us. But when a patient gets stuck here, they don't really need us anymore. So our nurses, who are incredibly well trained, are working below their level, right? They're really just providing sort of hotel care instead of acute nursing care, right? Our physicians are worried about, what about the child who needs us and is not able to get a bed? That happens all the time. In our PICU, we have a limited number of beds. There's always a demand for those beds, and we can't get kids into the PICU because we can't get kids from the PICU to the floor. We can't get kids from the floor to the home. So when somebody gets stuck in the hospital, it really limits our ability to meet our own commitments. And so I think that this discussion about how do we create the appropriate discharge for kids with complex medical illnesses will really help us move forward. What happens when a kid gets stuck? The way it feels. So our nurses, as I mentioned, get anxious because they're not providing the care that they're supposed to be providing. Our doctors get anxious because there are kids who need our care that aren't being able to come into the hospital. It also creates a huge amount of moral distress because we get frustrated with the system and we start to lose faith in our own sort of wider system because kids can't get to where they need. We worry that discharge won't be safe because there's so much pressure behind it. So it really turns our whole system sort of upside down and prevents us from providing the care that we want to provide and from meeting our own vision. So overall, I'm gonna, I know that we're gonna talk more about the ethics of this, I know we're gonna talk more about the notion of moral distress, but I want to sort of close this part by saying that we are tremendously committed to the care of these children. We are looking forward, we are working hard towards innovation, looking forward to more innovation. But we need a system, we really need a system that supports these children, inpatient, outpatient, throughout the whole system, so that kids don't get stuck in the worst place in the world is the hospital. Like, nobody wants to be in the hospital, right? No kid wants to be in the hospital. We need that system to really support children and to support our providers and to support children's families in providing the care that we really want to see. So I'm thankful for this conversation today. I'm thankful for a chance to sort of look past today into tomorrow into a way that we can really smooth this out, combine, collaborate with all the people who care. Everybody in this room is here because they care about this. All the different systems care about this, but we need that collaboration. We need somebody to be able to help us look past our own silos so that we can really focus on the child and ease the life of that child. So thank you very much.
I love the last minute editing here. I appreciate it. I had an opportunity to meet Becky and a colleague that I've worked closely with for many years called Brilski at the Families First Summit. And as she said in the introductions, I recently moved to work for the state of Maryland, and it's a privilege of mine to work for Rebecca and the Executive Leadership at Social Services Administration and the Department of Human Services. It was something that I had always seen myself doing, having spent the 18 plus years working directly with families, and I so appreciate your testimony today of what you're doing. I have a great respect for the families who are caring for their children and getting the supportive services of the Social Services Administration and the local departments, but also of those that come alongside families that can't care for their kids, and recognizing how much all of, no matter whether it's a child of yours from birth or a child who you're caring for in foster care, the great privilege but also responsibility that brings. Let me talk a little bit about, I prepared some remarks for the talk tomorrow as well. So I'm going to give kind of a broad overview of what we're working on within the Social Services Administration and child welfare, and then hopefully hone in on the outcome piece of it, because it is something that, of course, we're always looking at. Several years ago, the Social Services Administration started a couple of initiatives, Families Blossoms and Place Matters. And now there's groundbreaking legislation called Families First Prevention Services Act. And within all of this, there are some central values that we are promoting throughout the state that are really important to, I think, this discussion of working with this population of kids. And that is, we believe in family-centered, community-focused, strengths-based, and trauma-responsive services. And our aim really is three things. We want to prevent and divert kids from coming into foster care. And I think, the testimony, again, that you heard from Mom today says why. I mean, kids deserve to be with their families as much as possible. And we know that sometimes that's not possible. But we do want to reduce the need for out-of-home placement. And when kids do have to come into care, we want that to be, we want their permanency or reunification with their family to be timely and lasting. And so those are the values and the three outcomes that we're really aiming to serve as we look at our strategies. We are currently rolling out with our workforce, and again, as you can imagine, working with the most vulnerable populations around the state, and this one, I think, being the most vulnerable when you think of the fact that they oftentimes can't speak for themselves. The myriad of issues that our workers and our workforce has to deal with are great. And so we are working on rolling out what we call our integrated practice model. And a key part of this model is the inclusion of practice profiles. These profiles are behaviorally focused documents that are written for the frontline staff and supervisors in child welfare to assist them with management, practice, and activities related to specific focus areas. And I just want to say that I think as we continue to build on those practice profiles, we would love the input of those that are here today and tomorrow at the sessions about developing practice profiles specifically for working with families with children and children with complex medical conditions. There are several ways that children come to the Social Services Administration or to the child welfare system. As you know, as many of you may know, we have child advocacy centers in each jurisdiction around the state. Our child protective services teams and family preservation teams are working closely with local care teams and others to make sure that the needs of families are being addressed. Our local departments serve on those local care teams, and it's really important that we talk a little bit about that collaboration. And I'm looking at another partner of ours, Janet from DDA, who's going to be speaking with you tomorrow. But when we say partnership, it's true. The collaboration, both on the local level as well as on the state level, has really increased over the last few years, and I think has meant for some very positive outcomes in terms of identifying placement gaps, services that need to be put in place to support families. So I do want to talk a little bit about the fact that those collaborations also include the collaborations with the MCOs, the managed care organizations. So when we are governed by the regulation of making sure that every child that comes into care receives, is served by the MCO, that they're enrolled in services in their jurisdiction where they're placed, and that they're appointed a special needs coordinator. And from my understanding, the special needs coordinator relationship with the local department worker is really vital because our workers aren't necessarily trained in the medical issues that the kids come to bear. So while they can provide, I think, a really essential service of case management, making sure that those linkages and supports are in place, they oftentimes are at a loss for, how to help the families and deal with the myriad of medical issues. So that special needs coordinator and the connection with the local Department of Social Services, I think, is really key. And again, I appreciate, Becky, your offer. The whole thrust of this 2 days is to look at how we can work better together. In terms of what we're tracking with children of medical complexity, we are looking at every area of work really and using a continual quality improvement process. Some of the things that my team, the placement and permanency team, is looking at are things like placement stability, permanency for children, child safety while they're in care. And of course, there's a child needs and strengths connection. What are their needs and what is the connection to services that are required? And so we are looking at this now with experts from around the state and child welfare and other areas to provide some strategy and strategic direction. And I think, again, I would welcome those of you who have expertise in this area to participate in this implementation team and planning, because I'll give you an example. A local department shared that they have definitely seen better permanency outcomes for the younger children who are coming into care that are medically fragile. But the children who come into care with medical needs that are older are oftentimes not finding that permanency either, whether it be through adoption or reunification. And some of the things that they've found to be helpful to finding permanency are our adoptions assistance programs, helping families financially, helping families stay connected to medical assistance, but also meeting the caregiver's needs and looking at how when the child is placed at 2, and then they're still there at 10, and now they're 100 pounds heavier, and maybe their special needs have increased. How are we providing respite care services for those families? How are we, making sure that there's other types of medical supports going into that home? And so I do understand there's a lot of great partnerships with the coordinating center and the Parents Place, and a lot of these partnerships have proven to be really helpful with that. But I think that piece of stability, both when they're in our foster care child welfare system, but also when they reunify, what are the things that families are telling us that they need in order to maintain that stability. So I'm not sure, am I doing okay with my time here? So again, we welcome those of you in the room to be a part of those discussions, especially around the unique needs. I think that a few areas that we'd like to better track would be the recruitment and retention of foster parents and the family-based resources. I think I said this before, but Place Matters and Families Blossom are Families First. It's very important that kids are placed in family-based settings because they can get the kinds of things that you talked about. You know, the trips that you take with your daughter, the care that the siblings provide. And so just like any child, I think that improving our recruitment and our retention of family resources is important. We also want to look better at the health outcomes. We do have a new well-being unit, and there is a policy analyst that looks at the healthcare needs. So, and she's helped me prepare some thoughts today. So I know that they are looking at working on facilitating better connections between the MCOs and the local departments. There's a lot of really good work going on with regard to this. But looking at the health outcomes and the timeliness and effectiveness of service provision. And then, of course, what is stakeholder feedback? What are parents saying about the services they're receiving, and how can we take that and input and get their input so that we can make some changes that really have an impact on their experience in the foster care system. So, thank you so much for the opportunity. I'm glad I could step in, and I look forward to your questions.
Honored to be here and to join everybody on the panel. I do have to confess that the last concert I went to was the Wiggles.
Oh.
So I'm going to be, I almost feel at times overwhelmed when I think about children with medical complexity and the variety of issues that we need to think about and the challenges that we face. So I really want to emphasize, I think we both have urgency. We need to be thoughtful about the way that we proceed, not to the point of paralytic caution, but there are such desire to fix system problems, there's such a desire to do the right thing for these children and their families, that it can be tempting to think that the solutions might be easier, more clear-cut. And what I'm going to do is just note from both an ethical point of view and a microphone point of view, that we need to perhaps slow it down and really think it through. On the one hand, the urgency comes out, as many have noted, Becky in particular, because we're seeing an epidemiologic transition. At the end of this century, people will look back and say at the beginning of the 20th century, something fundamentally different happened with children who heretofore would have died. We are able to keep them alive, which is wonderful, but they have not been cured. They have continued with high states of functional impairment, but even more, if you will, complex-wise, physiologic degrees of impairment that have made them highly vulnerable and reliant on the healthcare system and the families that take care of them. What are we going to do with them? Because they're a characteristic population that we now take care of, it simply was not there before the advent of ventilators, home TPN, etc. The caution comes out of the second aspect of this, that medical complexity is not simple. It has emergent characteristics from the types of problems that we see with children who are not complex. For example, many of the solutions that we have of even how we present on rounds, a system-based, item-by-item way of thinking about medical care in the hospital setting doesn't really work well when there are interactions amongst the problems and high-level trade-offs over how we're thinking about managing one problem versus managing another. So what are we going to do as we have to advance our thinking about managing medical complexity and not assume that the standard ways that we typically dissect and analyze and manage a simple problem. And a simple problem may be life-threatening, but it is a different type of problem than a complex problem. Because of these interactions amongst components of a child who has medical complexity and the trade-offs that sometimes have to be made as you manage them. You mentioned the spinal rods. It sounds like that was a rough go. Yeah. Sorry to hear that. One of the people in the audience, Jay Berry, is working with surgeons up at Boston Children's Hospital. I don't want to steal Jay's thunder here, but really trying to re-engineer the way that the preoperative, operative, and postoperative management of young people going in for spinal rod therapy, surgery, is managed. Why? Because there are things that slip the attention. If you're an ologist, you don't realize you also need to be managing other things. And those other things need to be optimized before that patient goes into the operating room if you want to try to have the smoothest recovery possible. And there are also inherent trade-offs. It may be a year of school that is missed. And some families, okay, we're ready for that, and other families may not think that that's the trade-off that they want to make now or ever, particularly if the trade-off is not just about school, but even bigger concerns. And that's where we get into some of the trade-offs that involve ethical issues. So, hearing where we're going, I'm going to change the case in my mind of Royce. I was going to talk about one patient, but I'm actually going to describe, it's not the patient's real name, a girl who is 9 years of age, has been cared for by her mom. The girl has a syndrome with many problems, similar to what we've talked about. You know, umpteenologists involved. And the mom has serious mental health problems. Part of the problem is that over time, these health problems for the mom have become more difficult for the mom to manage her own needs and take care of her daughter. The father, they're not together, but the father and the maternal grandmother see this, and they've started to advocate with the mom that there needs to be a change in who is actually going to take care of the daughter. So they're not even involving a system of care. This is all being done within the family. When it was ultimately decided by everybody, including the mom, that this young woman was going to move to the dad's house, and all of that equipment needed to move to the dad's house, and the dad needed to rework his work schedule. And meanwhile, Child Protective Services that had gotten involved are sort of hovering. I needed to do the kind of thing that would drive Dr. Moon crazy. She needs to stay in the hospital until we have worked out every single detail, because I have to take care of the girl. I also have to take care of this father who is assuming new responsibilities. And the discharge plan is going to take a lot longer than anybody is naturally comfortable. Now, I will say, in a little bit of contrast, when we start to talk about systems of care, the administrative system of a hospital has different types of problems than the frontline staff, and that is different again than the patient and the family. We forget that, it's naive to forget it. All of the interests are valid, but they are different and not always aligned. So when I'm a frontline clinician, I have to tell my administration, I'm sorry, I'm going to occupy a bed with this patient for the foreseeable future. I believe that the patient still needs us. They may not need the top of our care, but they need our care because there is no other pathway forward for a safe discharge. And that's the definition, to me, of a need. Now, I do agree with Dr. Moon, it would be lovely if there were other options, that need could be fulfilled through other means. But this is one of the predicaments that we get into when we talk about medical complexity. Even more to the point, this boy, who I will call Duke, 16 months of age, terrible hypoxemic ischemic encephalopathy, very bad seizure disorder, and almost autonomic instability, so every little thing will get him dystonic and set off. His mom, unfortunately, suffered a stroke at the time of delivery. And she voluntarily eventually decided that she had to surrender custody because she was not able to take him back under her care. This was, again, her decision. It was not imposed on her. The problems for Duke are many, and they are life-shortening, inevitably. And the mom, along with the care team, along with many other people, had decided that it would be in his best interest to have a DNR order. When he became into the child protective and the foster system within, not even foster, but the protective custody of the local jurisdiction, one of the huge issues that comes up over and over again is how do you continue, or can you continue, or is it the right thing to do to continue the DNR? We worked extensively with our local jurisdiction. We had done so over the course of years to make sure that these children weren't being discriminated against and not being allowed to have access to protections against extreme forms of medical care that are likely to not be effective and not in their best interest. That is a very difficult area to navigate with even the best of circumstances, but it requires a lot of attentiveness to working the relationships with the local agency and the courts and the people who potentially are advocating from the clinical and the family point of view. All right, why caution? And I have less than 1 minute, so caution is going to speed up. There's work going on, a number of people, some very good work to try to define what this group of patients would need, including really recognizing the individuality, numbers 2 and 5, and the challenges of recognizing that individuality. If you look deeper in the article, that we need to not only measure symptoms or desires, outcomes, but how much the family cares about those outcomes. Again, if I can go back to the spinal rod surgery, the outcome of potentially pulmonary health and sitting comfort against the outcome of school persistence. Now, we've known, work that I do at the deep end of the pool, more with very severe illness, the parents often have different preferences. These are what we call good parent beliefs, things that parents feel on the inside that they need to do to be a good parent. 200 parents, you can see there's a wide range of the degree that they feel that these different items are really important to them. That's the key point here. Not that there's a number one, it's that I have no idea as I look around the room, if any of you were a parent, what you might be thinking you need to do. You have to ask. Now, if I shift that and actually juxtapose two different priorities, focusing on comfort versus focusing on health, we can see it that we had an intervention that actually improved both. That's no problem. Everybody will vote for that. But what do we do when there's a trade-off? When I say the surgery is going to take a year, 6 months, even 3 months of your child's life, and we're not absolutely positive what benefits will accrue from it, but we think that these might be the benefits, different parents would prioritize that differently depending on underlying preferences. We have very little in the way of established ways to evaluate those preferences and build them into the decision-making process. When we talk about children, Gabby coming in with all of her late appointments, we don't even know how often a child should be seen for routine follow-up who's medically complex. When she's not gaining weight, I have kids admitted onto my service where we can't even get them to gain weight. And we lean on the parents as though they are somehow failing. We need to have more caution about believing that we have this all sorted out already and we're ready to start moving quickly to a new future. I mean, there are some simple ideas. We need more intermediate care units. As much as I'm a believer in family, if you don't have an intermediate spot, the system is going to bust at the seams. And it puts too much pressure on families to take children back home immediately. So there are some low-lying fruit, and that's just a money problem. We need to find funds to support that. But we have to actually think about what it means to manage complexity, acknowledging it ain't simple. Thank you.
Thanks very much to our panel. Thanks for being here. Thanks especially to those of you who stepped in at the last 5-minute moment. We really appreciate it. Really grateful that you all have come come to share your different perspectives. Really grateful for the diverse audience. I see lots of people from different places, lots of people I don't know in the audience, which is fantastic. So thank you all for being here. I think you all have really important perspectives to bring to the table as well. So we're going to open it up for discussion now, and I'm guessing that people have lots of questions. I thought I would just start it off by saying, when I hear you all talk, I hear lots of areas of overlap between what people think are good outcomes for children with medical complexity, but there's also some areas that are, I'm not sure if they're in tension, but certainly they're in competition. So for instance, the desire to get a child out of the hospital as quickly as possible because that frees up beds, because that gets children home with their family, it meets multiple needs. In contrast to a family who doesn't want to take home a new piece of medical equipment. So there are competing needs as well, and I guess a big part of our discussion tomorrow is about what's the right way to weigh and prioritize these different issues, and especially as we think about targeted collaborations. What examples do people know of? What are we doing already in the state of Maryland or in other places that can help us figure out how do we balance these competing perspectives? How do we navigate these sort of high-level trade-offs that Chris was talking about? First, I'll open it up to my panel, but I'm guessing that there's people in the audience who have ideas as well.
If I almost apologize, I'm a palliative care physician in part, and I always go after the thing that seems to be a bit of the elephant in the room, which is these tensions across different layers, and even tensions between different organizations.
Yeah.
Not by design or purposely, but actually understanding them so we can manage them. There's good intention all around. That's one of the themes I think that needs to be developed, of respecting the differences and the tensions that grow out of that, understanding them and seeing whether we can be clever enough to find solutions that work for everybody, but not skirting the issue.
And I'm going to add to that. I think we've had some pretty interesting experiences in the Children's Center in the last year with children who really did get stuck. And from the hospital perspective, we decided to create sort of a broader team that could reach out more aggressively to the city and the state to say, we need to do something. And what came out of that was some amazing successes, but also a real understanding that we're not using the same language, we're not hearing the same stories, we're not responding to the same pressures. And what I really wanted to know was to learn more about how do we create that space, that arena, where we can share language and pressures and understanding and move forward. Because it is amazing. I think you and I have talked. There are so many different silos that we can't get past. And really, it's even like the use of language. We're not even hearing this the same way. It's been a remarkable experience. It really took me aback, right? We need to start from a very basic place to bring together, as you mentioned, all these people who are trying to do the right thing for all the right reasons. But whether there's some wonderful fable about sort of everybody touching a different part of an elephant and nobody really knowing what it is, I don't remember the fable, but that's sort of where we stand, right? We're not in that same important shared arena, and that's a wonderful challenge.
Are there questions from the audience?
Hi, I have a question regarding a commentary on a patient I have that I thought maybe someone could comment on, and if it's too broad for today, I understand, or a whole other issue on its own. I have a young boy that I am one provider of many. I care for this child's neurologic needs, and he has profound intellectual disability and spastic quadriplegia. He's cared for at home by his mom, and there are a couple of siblings in the home, and Right now, he is very small, and his mom feels very strongly that she would like to be able to care for him in their home for as long as possible, for their family life and for the safety of this child in the future. And she had to go very far from Maryland to Colorado to have hormonal therapy initiated. And I was just thinking in terms of forward thinking here at Hopkins and about placement, and then you had commentary on maybe things to that nature being discussed in the Hopkins community for these families.
So I'll talk about it for a second from, it's a really important question. And it's a question about a lot of different things. One of the simplest is, the ethics of patient care and what it means to provide appropriate care. And there's a huge, and I think, Chris, you know a lot more about this arena than I do, but there's a lot of disagreement about what's acceptable. I feel like if we can always start with this belief that a child is best when the child can be at home with family, and we want to make sure that that works for families, there are some bright line limits. And it's the problem is that people have a different sense of where those limits are. I think interestingly, even in our own intensive care unit, I see some of Dr. Schwartz and Dr. Berkowitz are here. There's a difference in belief about where the limits of acceptable care might be. So I think, I'm not sure that this is a discussion that anybody has come up with a broad understanding on, but I would love to hear what Chris has to say about it, because I think you've worked in this space.
One of these buttons.
Hold it. Push the down, left, bottom left.
There we go, thank you. That's the collaboration. So you're asking about the so-called Ashley X treatment, and there's a lot to say about that, but I'm just going to focus on the estrogen aspect, the high-dose estrogen to accelerate the bone age maturation and sealing, so that children who are treated with high-dose estrogen will wind up being somewhat shorter, depending on when it started, than they would have finally become. Correct? And that's also for everybody in the audience. And you're asking me to step into an incredibly controversial area, but I will. To say simply this, that it became very quickly politicized, but it's a quintessential example where perhaps the right answer is different for different people, depending in part on the child, including issues like how close to puberty are they, how much of a growth attenuation are you going to get. Height attenuation is not stature attenuation, so you could wind up with a shorter person who weighs exactly the same amount, and that was never really factored into the thinking. I also think that it's possible, though nobody's written about it, that a earlier sealing of the bones would potentially prevent some of the scoliosis that we keep coming back to. So there's a number of medical issues, but what's ultimately, if you could take a pill and stay at home with your family in your state of impairment, but also some degree of awareness, and that pill would hurt you to some degree, but you got to stay at home, how much hurt would you be willing to take to be able to stay at home? That's ultimately what I think that this is about. Now, that particular case, there's more to say about, I think, some of the thought process that went into it and other things that were done, so I'm not talking about that specifically. But in general, there are some people who would say there's no degree of harm, quote unquote, that we should cause to a child to enable them to stay at home. And I view any shortening or any alteration of their physical body as a harm. I think that's rather, that's one side of the spectrum. Because we do many things to keep children at home. We not with regard to that, in terms of the tracheostomies and other things that we do to facilitate care. So I see it as part of many options that we offer to try to make the child be as happy, or what does happiness even mean when you're not aware enough to actually even be able to say I'm happy. Fulfilled, meaningful, connected, loved, cared for. I mean, it really goes back to what's a good option, what's a good outcome for a child like that. And it may be part of a package of care that would enable that to happen.
I do think that this is also one of the issues that makes working in this space where there's multiple different systems involved very challenging. I mean, I find that for many of these children, the medical decisions are not always totally straightforward. It's not just obvious. You go to the dentist, you treat a sore throat, you treat a UTI. There are many complex medical decisions, and so we're trying to communicate across systems about these medical decisions that are not entirely straightforward. It just really ramps up and is really, for me personally, part of my passion for why I'm here today and brought us together today is because this space is really particularly complex. Other questions from the audience? Yes. Go ahead.
Hi, my name is Phil Sagos. I am a foster parent with Therapeutic Foster Care at Kennedy Krieger. I'm also a PFAC member, and I learn so much every day under the tutelage of the Brilskis and being a PFAC member and so forth, and being a foster parent. All these conversations that you're having, Dr. Moon, Ms. Marini, this is, as foster parent, that all swirls together. And to me, I'm thinking to myself, what is the common themes that would be helpful? Because I have a foster child who, unfortunately, the MCO said, you know, at past 1 a.m., we cannot cover that child anymore. And yes, he has burn, is a burn victim, we cannot cover that. On the opposite side, I have a daughter who we adopted, who has had, she's 6 years old, three heart surgeries, and she spent about 10 months going back and forth between Mary Washington and Johns Hopkins. So you mentioned the bed situation, stuck in the hospital. So I have both, and I'm thinking to myself, what can we do? Maybe, and I'm thinking to myself, maybe MCOs, conversing on a more regular basis with social services from the different counties. I mean, my daughter was Carroll County, so now as far away as Colorado, and I'm thinking to myself, that was a big thing, a big play in their parental rights going away because they couldn't take care of them. You know, it was Carroll, it was shorter than Colorado, but still they couldn't come to play. So I would say probably the more interaction, the quicker a response time. I've learned in having children from different counties. Each county has, and the city has its own policy. The county would keep the little one who had the burn until the morning. They wouldn't kick him out at 1 a.m. So, and maybe with Carroll County and so forth, maybe Lisa wouldn't have been in the hospital for 10 months. I don't know. But I would say that the quicker involvement from social services and MCO coming into play, hopefully getting on the same page. I love the fact that we're having this conversation. And sir, and to your point, Dr. Fortner, it's one of those things that we sell. If we can only help this child, because we're the pseudo parents, where's those limits? You mentioned the limits, the yellow line limits. You know, is this the best care for this foster child? Because we are their temporary parents as they seek reunification or they go to placement with an adopted home. So, wonderful. Thank you again for having us. But I would say, again, starting that conversation between the MCOs and the social services, getting on that same page with the same language would be perfect.
Thank you. I think two things I hear in that strike me. So one is about geography and how much geography matters, and we're going to be talking we're talking sort of in general today. We'll be talking a lot tomorrow about Maryland, but even within the state of Maryland, as you cross county lines, things are different. And as myself a physician working inside the hospital, I often understand none of that. So really important about geography. The other piece is quick and timely and efficient communication is not rocket science, and yet it's so hard to do. And I feel like one of my own personal goals for this session is just to know who every person here is and know how to reach you when I need you to talk about that thing. Because I do think it's not a huge community of people who are caring for these kids and families and who are sort of at the center of this. Many of you here are with me at those other meetings too. So it's not a huge community, but if we know each other so that we know how to pick up the phone or reach someone, I do think that can be helpful. Great. Other questions?
just to clarify, PFAC is our Patient and Family Advisory Council, for those of you who don't know it. And it's a tremendous resource for those of us who are trying to make care better, because we learn so much. Just like, your discussion of the day-to-day care of your child, we don't get that. So it's our Patient and Family Advisory Council that brings us back to harsh reality every time we try and get too pie in the sky about some of this stuff. But the points you're making are absolutely wonderful points. The day-to-day, the families are really the ones who bear the burden of this, our day-to-day inability to share that language.
I thought I'd just respond quickly. Thank you so much for becoming an adoptive resource for your child and also for caring for the child in your home. I think as now operating from a state perspective, it's clear, especially with our private providers who sometimes do have children placed from different jurisdictions, that it's really important that the consistency is there, and it's frustrating when it's not. So how many in the room are caregivers, either foster parents or parents? Okay. So I think, again, I think that's true often in our audiences, is we don't hear directly from them, but I bring that point up again because there are those things that happen on the level of the family that you often don't hear.
Yeah, and I would just add, and I do have a voice, so not just a pretty face. So I quickly delegated speaking earlier to Debbie, but I think the issue around language is important, but also from the standpoint of kind of the realm of possibility. So the example that I use is for us from the social services standpoint, when we get a phone call saying we have a child that is being discharged, needs to be discharged, and we need a placement and these are their needs, on a Friday at 5,
Classic.
makes it really hard to be able to be responsive, even in the midst of if we had a family resource available, right? So it's thinking about how do we better keep the communication happening before it's a kind of decision point. Like, what do we know that's going to lead up to, let's see what all of the cards are that we can put out on the table so that we're ready when it's time to make a decision. And I think that goes across the systems of kind of trying to not only sharing language and understanding what our what we're saying to each other, and but also thinking about the time and process that we need to build in a little bit better in order to allow all of our systems that don't move quickly to better align with each other. Dr. Moon has the answer to that.
Okay, the Friday at 5 thing. Honestly, we try really hard to avoid that, and it is funny. It's actually pretty. We're pretty good about not doing that, but it is. Sometimes things just build up, and all of a sudden, oh my gosh, it's Friday at 5 o'clock. It does happen. Friday at 5 o'clock comes no matter whether we want it to or not. It still comes, and so yeah. But that's a really nice point, and I think part of what you're saying is respecting each other's systems too. Like, the hospital might run 24/7, but happily your office gets to go home at 5 o'clock. We don't do that. So it's like we sometimes we have to remind ourselves that, a little bit of patience is worth a lot. Monday will come eventually. And so yeah, that's a point well taken.
I guess the other thing that I'm hearing is that if we had more consistent, non-urgent opportunities to talk with each other, that would help when things become urgent.
Just a quick, my hospital, we're unfortunately not 24/7, 365. I mean, we are, except when it comes Friday, everybody's disappearing and overnight. And meanwhile, I know I can usually reach somebody in social services pretty much anytime. So, but I think that what this is really suggesting is that it's not just the child that needs us, it's also the other systems that may need us. And one of the issues is how to expend our time and energy in anticipatory work that may actually never come to pass. So it's a bit of a gamble. If I call you on Monday and say, okay, Royce, I'm starting to have the heebie-jeebies about whether mom's going to be able to take him home. We've talked about this several times, and I'm actually going to lean to because we've seen some readmissions lately, I'm going to talk with her again, and so maybe it's going to be Dad, but I'm not really sure. So that's the kind of, should we even have that conversation, is the rapport that needs to be there. It's like, I'll get back to you as soon as I've had the conversation with mom, and then it may be that occurs on Wednesday at 5 o'clock. But it turns out by the time we get all the equipment, it's not going to be possible to discharge into the other home setting until next Wednesday. Because there's a whole bunch of stuff that needs to happen. So we're dealing with a complex system, and that's part of the issue with children with medical complexity. You're not dealing with just a child. They're first and foremost in my mind, but you have to work all of the systems and think about what are their timelines. I often say on my service, I manage time as much as I manage anything else.
I think it's a great point, Chris, and it makes me think about your point about how in the hospital, you know, even the way that we do rounds on these kids doesn't really work because you divide them up into organ systems, and these kids can't be divided into the organ systems very well because they all overlap. And it makes me think about, you know, when I have a child who is likely going to need some form of home nursing and the family wants to audition or meet different home providers before choosing one, and the question, I guess, basically comes down, how much are we willing to fund and support these preventative kinds of conversations, these early kinds of collaborations that might, as you say, in the end do nothing because it turns out the child doesn't go home, or it turns out they move to Colorado, or it turns out we never need that. But how much is it that children with medical complexity actually deserve this extra level of communication and preparation, even if it doesn't always pan out, because for many kids it will help. And I do think that this kind of work is this sort of unpaid, unsupported work in our hospital that I hear a lot of people complaining about. Other questions from the back?
I was just going to add one other point, and you just brought it up, was the conversation about the finance. I understand, and if the two panelists from Social Services Administration can speak to this. My understanding is Maryland has some type of caps, and I don't know quite what financial caps there exist. That's something that needs to be discussed as well as we go through, as you're using your example, Doctor, from Monday to Friday. This is great, we have a plan, but how is that going to work with insurance or with state funding for each child based on whatever their medical condition is? So that's why I would ask that we also discuss as well, or give food for thought.
Absolutely true that the funding in the state has a huge impact on all of these things as well, absolutely. And we are tomorrow going to have some discussion about that as well. So absolutely part of the discussion. Thank you for raising it. Oh, Karen, yeah.
So a quick comment for me about the first question. So I'm Janet Crane, I'm a pediatric endocrinologist, and I take care of these kids once they get osteoporosis. And so they come to me and ask the question that your patient asked because I'm the endocrinologist. And so a lot of these questions are coming in very late from these families about what could I have done to keep my child small. The parents of the females are asking, how do I manage their periods? And so a couple of things that I would bring to the table and ask is that as an endocrinologist, I come to the table fairly lately, and I can help them if I could get to them sooner. And so it's a lot of somebody else knowing what options there might be out there and then referring to us so we can have a more in-depth conversation and a lot more time to think about if we should be doing what is the right decision. A lot of times the decision is, no, let's not do anything, but still allowing the family to get that sort of time. The other perspective that I would like to bring up is most of the stuff I do is on the outpatient basis, and we've talked a lot of the inpatient stuff. So some of the frustrations I've gotten from my families is how to coordinate their care outpatient to use their time efficiently. If you're packing everyone into a van and it requires, why in the world would you come for a 15-minute appointment? And if there's some way that we as a group can work with each other to see these patients on the same day, is always ideal. And then when they come into the hospital, they often get frustrated because I'm on service 4 weeks out of the year. I'm not their endocrinologist that's going to get consulted when they're inpatient, and working out some sort of system that there's some other way that we help take care of these kids so the family's getting some sort of continuity.
Thanks for that, and I think we'll have lots of discussion tomorrow about the idea around models of care, programs of care for these children, whether they're complexologists or specific groups that take care of these kids, particular specialists, designated specialists, one from endocrinology, one from pulmonary, one from GI, et cetera. Do we have, day-long clinics where people come in and get everything done? Do we do more telemedicine, et cetera? So I think there are a number of models out there. One of the challenges that I see in some of the models is these kids are really expensive. So in my limited and humble experience, getting people to invest more in new programs for these children who are very expensive is a challenging math. Figuring out what the potential dollars saved are is challenging, but we have smart people in the room who are going to help us with that. I think Karen had a question.
I wanted to just go back to a very basic question, and that is the assumption that they're best off at home. And what does home mean? Does it mean biological parents and your siblings, or does it just mean getting out of an institutional setting? Could you talk a little bit more about what's behind that, and then what's really in the best interest of the child and their family?
Yeah, we're all
It's
challenged.
wherever they're safe. I mean, it happened in Alexandra's case that her safe place is with her family, but ultimately, I know I said my goal for her was to be happy, and I think that we provide her that happiness. But, what we had talked about in November was, does the family have the right electrical outlets? Do they have a ramp to get in the house if they're using a wheelchair? Do they, is their heat working properly? Do they have air conditioning? It has to be a safe place, I think, first. And then if they're with family and if they're able to be happy, then that would be secondary. But if they're medically complex, like we're talking about, they would have to be in a safe place that's going to have the electrical that they need for their medical equipment, room for them to get, or even through the hallways to a bedroom. Is it going to be a safe place? Is my gut reaction.
And also, in addition to that, but the challenge there is, what are the trade-offs? And I think Chris mentioned this already, like, how safe is safe enough, right? Wow. We can say that every child with complex medical illnesses needs to be, in the perfect environment, live only a block away from the hospital and but that's not what anybody needs, right? So it's a messy space. That's a messy question, because it's about safety, but it's not about perfect. It's about enough. It's about a balance between safety and love. It's about a balance between, having enough food or enough longevity or whatever it is, and being around people who look at you and care about you and try to make you happy. So that's a tremendously difficult question. And for every single child, the answer is different and has to be worked out every time you see that child. I think that's one of the amazing complications of caring for these kids.
Yeah, and I absolutely agree in regards to it's certainly individually based, but from the standpoint of, you think about child welfare's history, is we absolutely used to believe that kids did better off in foster care, and so once they were in foster care, they would just stay, and it was a success if they aged out from us and went on, which seems kind of a little ludicrous now, knowing what we know in regards to the importance of connections and stability. And so when we talk about family, we're talking about, in many ways, the family-like setting. It might be a family of origin, it might be a foster family, it might be an adoptive family, it might be a caring community where there's consistency, because what we do know is that consistency in caretakers, those that are gonna recognize when you're having a good day and a bad day outside of the medical things, is really what is going to be important throughout a child's development into adulthood. So I don't know that we necessarily have one prescribed way of saying what a family is, but I think it's what we know for the most part is the more kind of home-like setting you can have for a person, the more stable the relationship is going to be in their best interest for the most part.
One of the biggest social experiments that we've seen run in the last 50 years was removal of people with serious mental illness from congregate care, institutionalized settings. You look at the history of that, and some of the places they were being cared for were horrific. So on the one hand, we want to applaud it, but we've seen that you can have ironic consequences when you try to run your policy entirely with a philosophy, particularly if that philosophy happens to have monetary, fiscal implications that lower the total cost. So I think that's something for us to keep in mind, that there will be potentially strange bedfellows who would want to say we could save money in a particular way, and it would be more individualized. I do think that there are huge issues in the foster and the human service system about coerciveness and disenfranchising people who want to parent their child. But I also see a lot of parents who they desperately need respite. I don't even want to ask the last time you may have gone away on a vacation. Most parents have never had respite, never mind the foster parents, just any parent. And the second is there are some parents who are overwhelmed at the task and are not looking forward to it, and it is being pushed on them. And I'm not sure that who is benefiting from that, but these other options cost money. And I'm just waiting to hear all the arguments why they're actually not very good options, without focusing on it's a money problem.
So I love how everybody leaned in on that question, so thanks very much. It is time for us to wrap this up. I want to again thank the Levy family for making this donation that has made this day and a half possible. Thank you very much to our brave and wise panelists who bring lots of experience. Thank you to all of you who stayed here till 5:30 to have this conversation. We are, a subgroup of us are meeting tomorrow all day to talk about all of these issues. If you are not coming to that meeting, but you have a fire in your belly about this stuff, please find me or Becky Seltzer to let us know that this is important to you and that you'd like to be included in things going forward. Thanks, everyone. There should be refreshments outside. Feel free to hang around, meet each other, establish some collaboration, get phone numbers, email addresses. Thank you very much.